exploring how we can master ourselves by looking at how authors and experts say it is possible, with your host, Shashiti Basu.
Welcome to Season 3, Episode 93 of How to Be with me, Shashiti as your timid presenter, guiding you through life's tricky topics and skills by reading through the best books out there. Health inequalities are the unjust and avoidable differences in people's health across the population, and between specific population groups. It goes against the principles of social justice because they are avoidable. They do not occur randomly or by chance. They are socially determined by circumstances largely beyond an individual's control. These circumstances disadvantage people and limit their chance to live longer, healthier lives. The existence of health inequalities across many parts of the quote-unquote Western world means that the right of everyone to the highest attainable standard of physical and mental health is not being enjoyed equally across the population. So how do we get equal access to healthcare and stop being medically gaslighted? Here is Amanda Finley from Kansas City, Missouri, who talks about her experience of medical gaslighting.
10 years ago, after I had my son, I went through a very long spell where I was crushingly tired all the time, and I lost all of my hair. And I really think, had I not had something visible, I would have had a much harder time. But because I also carry a diagnosis of bipolar 2, I did have some doctors who told me I just needed to control my anxiety. And I remember ripping off my scarf when I was at my first endocrinologist office. She said, "Oh, your labs are normal. There's nothing wrong with you." I ripped that scarf off and I told her that, no, something is going on here.
Our first book is from Sarah Graham, who is an award-winning freelance health journalist and founder of the Hysterical Woman blog, specializing in health, gender, and feminism. She has written extensively on these subjects for the iNewspaper, Refinery 29, The Telegraph, Grazia, Guardian, the BMJ, and many others. She was a finalist in the 2021 Medical Journalists Association Awards. We're talking about her book, Rebel Bodies, A Guide to the Gender Health Gap Revolution. It was fantastic speaking with her, hence here is a snippet of our chat. But find the full interview on www.howtobe247.com or on the YouTube channel.
I think it's everything, really. It's kind of the whole sort of thesis statement of the book. You know, I think one of the things that I was really conscious of kind of as I was putting my book proposal together in the midst of the COVID pandemic was that health is such a kind of personal issue, but it's also a public issue. You know, public health has been such a kind of huge thing in the last few years, and it's not just personal, but it is political. You know, the political choices that our governments make have such a big bearing on the health of the people. And so I really wanted to explore all of the kind of very interconnected ways that health is both personal and public and political, that each of us has an impact on each other's health, that our political choices have an impact on the health services that we receive, and also that our political leaders have the power to determine the services that we have access to. It's one of those things where when you look back on the history of medicine, this idea of hysteria has been around for literally thousands of years. And that so much of the way that we think about women's health, women's bodies, women's hormones is still tied up in this idea that we're kind of almost slaves to our bodies, to our wombs, to our hormonal fluctuations, and that there is this idea within medicine where the male body is very much the default. That is the norm. That is still the body that doctors at medical school are taught to treat. And that anything that kind of deviates from that is other, is alien, is kind of almost inherently broken. And so I think that has a massive bearing still on the way that the medical profession treats women, not necessarily in a conscious way anymore, although I think, sometimes it is. But I think a lot of the time it is very much an unconscious bias that we see it a lot in this idea that women are more emotional, that we're more irrational, that, you know, we can't be trusted to kind of accurately report what's going on with ourselves, you know, that we're more likely to exaggerate. And so that has a huge impact on whether women are trusted, whether they're believed, whether their symptoms are taken seriously. I think the way that I talk about it in the book is there are kind of multiple different elements to it. So there is obviously that huge cultural and social element of bias and stereotypes. And that isn't just sexist stereotypes, but racism and ableism and ageism and all these different things that are kind of wrapped up within that kind of package of misogyny. So that, I think, is a huge part of it. I think a lot of it, particularly in an NHS that is under enormous pressure, and we're kind of seeing that the huge crisis that the NHS is facing at the moment, doctors have to almost rely on these kind of, one of the doctors I interviewed described it as mental shortcuts. So you rely on stereotypes because you have to make judgments and diagnoses really quickly. You haven't got time to sit and think about it and figure it out and tease out all of the different complexities of patient symptoms in front of you. So I think that capacity issue, that time, the workforce shortages all kind of play into it. And then, of course, you've also got gaps in knowledge where we perhaps don't have as much research around the issues that primarily affect women. We don't, you know, doctors perhaps don't have as much medical training on issues like menopause or menstrual health. So it all kind of combines together to create a world where, you know, healthcare professionals have less knowledge and understanding, have these kind of really deeply ingrained sexist ideas and biases that affect whether or not they believe you. And actually, if you don't have the knowledge to be able to make a quick, accurate diagnosis, sometimes it is almost kind of easier to blame the patient than to say, actually, I don't know. Like, as a doctor, I think that must be, as any kind of professional, none of us like to say, I don't know. That's really hard. And I think it's particularly hard for doctors because we have this kind of mindset of doctor knows best. Yeah, absolutely. I mean, BMI is a really interesting example of something where doctors are often very quick to almost kind of scapegoat people's weight. And we know that within the NHS, you know, BMI is sometimes used almost as kind of a way of meeting targets or, you know, denying treatments to people on the basis of their weight, saving money. And that's really problematic because it's almost kind of become socially acceptable for medical professionals to say, well, your symptoms are probably just because you're overweight. You need to lose weight before I can do anything. And for the majority of people, actually, their weight will have nothing to do with their symptoms. And losing weight is not going to help them. But it's kind of an easy way to fob people off and say, do this first, and then we'll look more seriously at it.
Graham's book firstly delves into the enduring influence of second-wave feminism's consciousness-raising groups, paralleling them with the contemporary Me Too movement. She highlights empowering gynae workshops, the significance of understanding women's bodies, and mentions figures like Germaine Greer and the Boston Women's Health Book Collective. Graham explores the concept that the personal is political, connecting personal experiences to broader socio-political contexts, emphasizing how health impacts life aspects like work, relationships, and political decisions. Gender bias in healthcare leads to financial and societal consequences, with conditions like endometriosis costing the UK economy £8.2 billion annually, and menopause-related issues causing 14 million lost working days. Despite these impacts, women's health concerns are often marginalized and under-researched, affecting individuals across gender identities. Gender discrimination results in health inequalities, high mortality rates for women in heart attacks, and alarming disparities in maternal mortality, particularly among Black women. Historical biases against non-cisgender, non-white, disabled, queer, trans, and intersex bodies have perpetuated gender bias in medicine. Medicine's traditional model centered on cisgender white males, marginalizing other bodies as other and disregarding their needs. Ancient beliefs like the wandering womb and Sigmund Freud's influence perpetuated misconceptions and biases about women's health, contributing to the dismissal of women's symptoms. Echoes of this bias persist when women are labelled as too emotional, hormonal, or overreacting, justifying their exclusion from positions of power. Medicine also has a history of colonialism, racial bias, homophobia, transphobia, ableism, ageism, and classism. For example, James Marion Sims' experimentation on enslaved black women without anesthesia perpetuated racial bias, and racial disparities in pain assessment and treatment persist. Trans and non-binary individuals also encounter similar biases in healthcare, with experiences of discrimination and lack of understanding. Overstretched healthcare systems further complicate these issues. Menstruation presents challenges for cisgender girls and women, but conditions like Mayer-Rokitansky-Kuster-Hauser syndrome, or MRKH, and premature ovarian insufficiency, which is POI, affect some, impacting body image and identity. The absence of comprehensive research on menstrual issues persists, with limited treatment options for severe period pain and underfunding for conditions like endometriosis. The gender bias in research allocation is evident, with more studies on erectile dysfunction than premenstrual syndrome, or PMS, despite the latter affecting more women. Endometriosis, a common gynecological condition, faces severe underfunding, causing prolonged diagnostic delays. Misdiagnoses, like advising patients to just get pregnant and attributing pelvic inflammatory disease to stereotypes about black women, highlight the lack of understanding in healthcare. Some gynecological surgeons perform unnecessary hysterectomies, while negative attitudes towards hormonal contraception in British Asian communities hinder treatment options. Funding for women's health remains inadequate, impacting research and patient care. Patients are advised to track their cycles and seek specialists for better care, according to Graham. A significant gender pain gap also exists, with women being less well treated for pain than men. Racial biases persist in medical education, leading to misconceptions about differences between races. And LGBTQ+ patients, especially lesbian, trans, non-binary, disabled, and Black, Asian, minority ethnic LGBTQ+ individuals encounter severely unequal treatment. The heart attack gender gap reflects disparities in heart attack care, leading to avoidable deaths among women due to inferior treatment. A&E doctors are not immune to bias and errors either. Fat phobia, as mentioned before, is common in the medical profession, with patients in larger bodies often having their weight blamed for medical problems. A health at every size approach, or HAES, is recommended to address this issue. Trans and non-binary patients face biases similar to cisgender women. Advocates and witnesses can be crucial when seeking care, and resources like Transactual provide information on trans healthcare. Disabled individuals, especially women, face disadvantages in healthcare. Chronic pain is prevalent, with disabled women having higher COVID-19 mortality rates. Research on female-dominant conditions is also lacking. Graham highlights the importance of seeking support and being prepared when dealing with mental health challenges. She addresses how women's emotional expressions have historically been viewed negatively, often labelled as irrational. However, feminist scholars like Elaine Showalter and psychotherapists like Phyllis Chesler have reinterpreted these expressions as reactions to female powerlessness. Women are disproportionately diagnosed with various mental health conditions such as depression, anxiety, eating disorders, and PTSD. Additionally, borderline personality disorder diagnoses are more common amongst women, while Black patients are frequently diagnosed with stigmatized conditions like schizophrenia. Women are also more likely to be prescribed psychiatric medications. NHS data indicates a rise in mental health issues among women, affecting 1 in 5, with higher rates amongst Black, Asian, mixed race, and LGBTQ+ communities, due to factors like bias and socioeconomic disparities. Women are more likely to suffer from trauma also due to interpersonal violence, which can lead to mental health issues and suicide attempts. This leads to the suicide gender paradox, which reveals that women attempt suicide more often than men, although men are more likely to die from their attempts. The underfunding of the NHS mental health system contributes to long waiting lists for support as well. Research from the Royal College of Psychiatrists highlights extensive waiting times for treatment, particularly for severe mental illnesses, and it can be up to 2 years. Racism within the healthcare system also results in disparities in treatment access. Borderline personality disorders, we mentioned, diagnoses are common amongst women, but some argue that these cases could actually be re-evaluated as complex PTSD, related to sustained trauma. This misdiagnosis can lead to harmful stereotypes about women's personalities. There is also a gender bias in the diagnosis of neurodiverse conditions like ADHD and autism, leading to undiagnosis in women and girls. Eating disorders are another area of concern, with disparities in access to medical treatment based on race, gender, and socioeconomic factors. The NHS provides options for self-referral to talking therapies and advocates for those facing severe mental health difficulties, offering support through friends, charities, or statutory advocates. As we mentioned, one of the other important aspects is the suicide-gender paradox. We mentioned that while men are more likely to die from suicide attempts, women actually attempt suicide at much higher rates. In 2019, data from the Office for National Statistics showed that the suicide rate for women was at its highest since 2004, particularly affecting those aged between 50 and 54. This complex issue is compounded by the underfunding of the NHS mental health system, leading to extensive waiting lists for support. Black British adults experience severe mental health symptoms at higher rates, but are less likely to receive treatment, resulting in a fourfold higher likelihood of being detained under the Mental Health Act. Eating disorders, another gendered and stigmatised mental health area, affect people of all backgrounds. Nevertheless, research from UK eating disorder charity BEAT in 2019 showed disparities in medical treatment, particularly for those in marginalised communities. NHS data from 2017 to 2020 revealed a 216% increase in hospital admissions for eating disorders amongst Black patients, indicating a significant problem with the BMI measure as well. Access to the mental health support in the UK is offered through the Improving Access to Psychology's Therapies programme, allowing self-referral instead of requiring a GP referral. For severe mental health difficulties, advocates can be helpful, whether they are friends, family, independent advocates from charities, or statutory advocates like independent mental health advocates. Graham also touches on the issue of sexual health, highlighting the gender orgasm gap and the lack of focus on women's sexual agency and enjoyment in society. Ignorance about female anatomy persists, leading to issues related to sexual pleasure and overall vulval and vaginal health. Medical research has historically prioritized issues like erectile dysfunction over female sexual problems, and intersectional biases affect sexual health care, particularly for women of colour, women with disabilities, and queer, trans and non-binary individuals. Female sexual dysfunction, or FSD, can affect anyone with a vagina, but sexist assumptions and attitudes persist. Psychological factors such as previous sexual trauma can contribute to conditions like vaginismus and painful sexual experiences, creating a cycle of anxiety and tension. Inadequate care is also a common experience for individuals with chronic urinary tract infections who are predominantly women. Reproductive health concerns continue with unequal responsibility for contraception, burdening women with decision-making and checkups. Policies like reduced chlamydia screening for young men reinforce the perception that sexual health is primarily a woman's concern. Some women face severe side effects from contraceptive methods like the pill or IUDs. Cancer is another significant aspect of women's health. Breast cancer receives more research funding in the UK than any other cancer, yet there are disparities in funding allocation amongst gynecological cancers. And whilst it is within the big four cancers, it's given disproportionately less than some of the other cancers. Language often portrays cancer as a personal battle, which can be problematic as well. Cervical smears have been stigmatised in the past, ignoring the risks faced by various groups. Innovative approaches such as redesigning speculums and less invasive HPV tests have sought to redress these issues. Pregnancy and childbirth also present challenges. Logistical hurdles and anti-trans bias affect trans men and non-binary individuals assigned female at birth, impacting access to gynecological care and cancer prevention. Inadequate support for those experiencing HG or hyperemesis gravidarum and limited choices for preserving fertility before cancer treatment are further concerns. Maternal care involves issues such as antenatal care, obstetric violence and coercion, with significant safety concerns in NHS maternity units. Racial biases affect maternal mortality rates, with Black mothers at much higher risk. Miscarriage affecting 1 in 4 pregnancies lead to significant mental health consequences, and support is often insufficient. We covered this in a previous episode on motherhood with Don't Forget to Scream author Marion Levy. The menopause experience is marred by a lack of preparedness and misinformed doctors. Women face significant challenges during this life stage, including ageism and dismissal of symptoms, and often resort to private menopause care. Ethnic minority communities face added challenges, and there's little research or representation for menopause in the LGBTQ+ community. Trans men and trans masculine individuals also struggle with the lack of medical knowledge about surgical menopause and testosterone treatment. Menopause-related estrogen decline increases the risk of various health issues, including cardiovascular disease and osteoporosis, contributing to gender disparities in these areas. At the most fundamental level, Graham says we need a properly functioning health service that requires funding for necessary equipment and infrastructure, but above all, it requires people, well-trained, compassionate, diverse, skilled people, and plenty of them. Adequate staffing levels are essential for patient safety, and we urgently need investment, not just in recruiting more doctors, nurses, midwives, and support staff, but also ensuring they're well enough paid and supported to do their jobs to the best of their abilities, and to keep them in those roles long term. We need research to bridge the many gaps in medical knowledge, have more women in senior research positions, and of course, funding in general. It's been a while since we had a trailer, but this was mentioned in Graham's book. Southern Comfort is a 2001 documentary film that looks at the life of the American Robert Eads, a trans man who's denied life-saving cancer surgery, which eventually killed him in 1999. Here he is talking about it.
And I wish I could understand why they did what they did, and why they had to feel that way. And I know in a way they've contributed to my dying here. But I can't hate them. I don't hate them. I feel sorry for them. I can't say I actually forgive them for what they've done. I think that's more between them and God. But I don't hate them. I guess what makes me most sad is that they probably feel like they did the right thing.
Our final book is a biography by Rebecca Skloot, who's an award-winning science writer whose articles have appeared in the New York Times Magazine, Discover, and others. She has also worked as a correspondent for NPR and PBS. In 2010, Skloot sold the film rights for The Immortal Life of Henrietta Lacks to Alan Ball and Oprah Winfrey, which is the book we're looking at with the same name. Here she is speaking on her own channel.
My basic biology teacher, when I was 16, said there are these cells that have been alive since 1951, and the woman they came from died, and she was black. Like, that was all he said. And I went, what? What are these cells? Or why? Who was she? And kids? And what are they thinking? Those moments, that's what writing is all about. Training yourself to recognize those big moments when they happen. They're the sort of what moments, and to just follow them wherever they're going to take you. The greatest responses that I get to the book usually starts with, I hate science, or I almost didn't read it because it was about cells and it sort of freaked me out, but then I couldn't stop. And a lot of what brings them to the story is the characters. The things that happen to them and the things that they do are really sort of too incredible. It's a story about family, and it's a story about what happens when you lose a mother, children trying to learn about their family, while at the same time, you're learning that you actually benefited from their mother's death. Every single person out there, there's not a single person in the world, really, who hasn't benefited in some way from these cells. I've had kids come up to me saying, my mom had cancer when I was growing up, and she's alive because she took this drug that they used HeLa cells to develop. So I feel like all of these things that the family went through when Henrietta died, I didn't go through because Henrietta's cells helped save my mother. I talked about the story a lot, which is something a lot of writers don't do. I would meet people, out at a dinner party or something, and they'd say, what do you do? Oh, I'm just writing this book. What's it about? And And I would always start off by saying, it's about the first immortal cells ever grown in culture. And they would go, like, really? They'd be like, no, it's interesting. And then I would start to tell the story of the family and the cells and what they did. And inevitably, everyone's reaction was the same. It was like their jaws would drop and they would just like, really? What are you doing out of your house? Go home and write this book because I want to read it. Good science is all about following the data as it shows up and letting yourself be proven wrong and letting everything change while you're working on it. And I think writing is the same way. And I think that the process of this book was that. I mean, I started writing it thinking I was just writing a book about the cells and the woman they came from. You know, what you imagine the unknown is going to be is never what it actually is.
The Immortal Life of Henrietta Lacks tells the story of a poor tobacco farmer who died from cervical cancer and her cell strand, HeLa, which scientists used to develop a cure for polio and other diseases. In a fascinating and revealing investigation, author Skloot uncovers the history of Henrietta and her family, of the exploitation of Black Americans by the medical industry, and of Henrietta's immortal cells. On August 1st, 1920, in Roanoke, Virginia, Henrietta Lacks was born, destined to make a profound impact on medical science. Growing up on a tobacco farm, she married her cousin David Lacks and moved to Sparrows Point near Baltimore due to financial struggles. In 1951, Henrietta developed a lump on her cervix, leading her to Johns Hopkins for diagnosis. She was diagnosed with cervical cancer and her treatment involved the use of highly damaging radium. Despite enduring painful and ineffective treatments, Henrietta succumbed to the disease on October 4th, 1951. Her legacy would live on through the unique contributions her cells would make to medical research. In the early 1950s, researchers aimed to keep human cells alive outside the body for medical experiments to combat diseases like cancer, polio, herpes, and influenza. Traditional methods failed to maintain cells in culture, leading George Gee at Johns Hopkins to invent the roller tube culturing technique. This technique involved rotating test tubes to mimic bodily fluid flow. Gee, with assistant Mary Kubitschek, was amazed when Henrietta Lacks's isolated cancer cells survived but also thrived, doubling every 24 hours. HeLa cells' aggressive nature coupled with Gee's technique enabled their survival, leading to groundbreaking research opportunities in various labs. After Henrietta's death in 1951, plans were made for a HeLa factory, aimed at mass-producing HeLa cells weekly to find a cure for polio. HeLa cells were cost-effective for research compared to monkey experiments, as they survived well in culture medium and could be transported across the country without significant damage. They were also highly susceptible to the polio virus. The National Foundation for Infantile Paralysis established the HeLa Distribution Center to support research labs, expanding HeLa cell use beyond polio research and turning it into a lucrative institution. The famous HeLa cells rapidly circulated among labs worldwide, yet the source of these cells were largely forgotten. In 1999, the author stumbled upon articles from a HeLa cells conference held at Morehouse Medical School. She contacted the organizer, Roland Patillo, the sole black student of George Gee, who revealed the Lacks family's reluctance to discuss Henrietta's cells. The family believed the cells were taken without consent and had a general mistrust of the medical industry due to historical exploitation of Black Americans, such as the Tuskegee syphilis experiments. After initial difficulties, the author sought out Henrietta's distant relatives in Clover, Virginia, hoping to connect with her immediate family. After Henrietta's death, her family faced financial hardship. Her widower, Day, worked 2 jobs while her son Lawrence dropped out of school to care for his siblings, who wondered about their mother's fate. Day forbade questions that might unsettle their lives. Years later, Deborah, Henrietta's daughter, demanded answers, but Day only revealed her name and that she died when they were young. The author sought answers from Henrietta's distant relatives, doctors, and eventually her family, building a connection. However, some family members remained hesitant to discuss Henrietta's HeLa cells, raising questions about their reluctance to engage with the author and the medical community. The author faced significant challenges in researching Henrietta's life because of the family's deep distrust of her as a white reporter and their apprehension toward the medical field, rooted in a history of exploitation of Black Americans. While some documented cases of exploitation existed, many stories circulating in the Black community, like the night doctors who kidnapped people for experiments, were fictional but rooted in the historical trauma of medical experimentation on slaves. Even though Johns Hopkins aimed to provide medical care to those in need, the proximity to a poor Black area intensified local suspicion. The history fueled the Lax family's distrust of doctors and researchers inquiring about Henrietta and her cells. After distributing HeLa cells worldwide for research, scientists hoped to discover cures for various diseases. In 1966, geneticist Stanley Gartler found a problem. HeLa cells had contaminated other cultures. They could survive in the air on dust particles and spread via unwashed hands and pipettes, undermining research on what were assumed to be distinct cell cultures. Some doctors took Gartler's findings seriously and sought ways to detect HeLa contamination, leading them to Henrietta's family for assistance. This contamination revelation raised questions about the validity of previous research and genetic characteristics of various cell cultures. The contamination of HeLa cells prompted doctors to seek the surviving family. As the family were patients at Johns Hopkins, obtaining their contact information was easy. Doctors aimed to use their samples for research on contamination and human genome mapping. In 1973, at Yale University's first international workshop on human genome mapping, researchers identified the need to locate Henrietta's children. Victor McCusick, who had published a paper on HeLa, asked Susan Hsu to find the Lax family and collect blood samples. Deborah's concern about cancer and her mother's history led to discussions with doctors and further blood sample requests. Henrietta's case is both exceptional and not unique. Her aggressive cancer inadvertently contributed to medical research, but similar privacy situations occurred in 2 other cases. John Moore, diagnosed with a rare cancer, had his cells marketed without consent by researcher David Gold, leading to a legal battle. Ted Slavin, born a haemophiliac, was informed about the value of his cells and collaborated to profit and advance hepatitis B research. Unlike Henrietta, Moore and Slavin had opportunities to contest the use of their cells, highlighting the complex ethical and legal aspects of cell research, particularly when informed consent and property rights are involved. The practice of isolating and marketing a patient's cell without their consent, as seen in Henrietta's case, was not illegal in the United States until at least 2009. The legality of such practices hinged on consent and financial considerations. While current regulations require patient consent for research samples, samples from diagnostic procedures can be stored without consent. Advocates argue that existing legislation and oversight are sufficient, but opponents contend that patients have a fundamental right to know how their cells will be used, particularly for ethical issues. The commercialization of cells raises questions about informing patients about potential financial gains. Gene patenting remains a significant concern, impacting ownership and distribution of biological materials. In 1999, the National Bioethics Advisory Commission highlighted the need for more patient rights in tissue research, but remained silent on financial matters. So to sum up, Graham shows the story of the gender health gap from the perspective of all those many, many real women and others whose voices and stories too often remain hidden behind the scenes in rebel bodies. These are the people who are living it, speaking out about it, and leading the long overdue revolution in healthcare by creating a manifesto for change. Skloot says in her book, The Immortal Life of Henrietta Lacks, that her cells, named HeLa, became fundamental to research into a cure for polio and other diseases. However, while in treatment, Henrietta was not informed, and so she died not knowing the incredible role her cells played in medical science, and also having her agency taken away as an African-American woman. Unfortunately, I am one of many women who has faced medical gaslighting for decades. From mental to physical health, I was put in incredibly dangerous situations that led to life-changing repercussions. How about you? Have you ever faced medical gaslighting? Let us know. Please join in on the conversation by following @HowToBe247 on Instagram, Twitter, and Facebook, and subscribe on the podcast, which can be found via www.howtobe247.com. We have Spotify polls, so feel free to send your responses there too. You can even check out all our exclusive unseen bonus material from every single interview, all for the price of a coffee, on both Spotify and Patreon under the name Behind the Scenes, exclusives from the How to Be Books podcast. All the latest ones are on Spotify, while more than 30 exclusives are on Patreon. Sign up to be part of the movement. Please do leave a review if you found this helpful and you want to be featured. And remember to check out the website. We had an exclusive story about Amazon's AI-written mushroom foraging books that could be seen as life or death. And we were also at the Queen's Park Book Festival last week, where we saw Zadie Smith talk about her new book, The Fraud, as well as Booker Prize nominee Ayobami Adebayo. Don't miss out on all the important things happening in the world of literature and the intersection of society. Before we go, here is Lisa Rowe, who is a licensed clinical social worker, the CEO of Support After Abortion, and a private practice clinician. See you next week.
The medical system combined with our mental health community is at large marginalizing women after abortion, with 1/3 of women after medication abortion reporting an adverse emotional impact, and very few able to identify safe, unbiased support. This is evidence that this population is being marginalized. Further, we receive calls on our abortion helpline. People share their lived experience in this space. Oftentimes, they share their encounters with the mental health community, and they express concerns regarding their minimization of their pain or the invalidation of their pain. This might look like a client sharing their experience with a clinician, in which the clinician responds by saying something like, "That's not the reason for your pain," or doesn't ask about their abortion experiences. These two issues create a space for people to push further down whatever experience they have related to their abortions. And then it causes a ripple effect as they try to create new and different spaces in their communities. It often causes maladaptive behaviors and dysfunctional choices.